about class 2 division 2 malocclusion. So we'll start, this is the second lecture after the class 2 division 1, and today we're going to discuss the class 2 division 2. We're going to discuss the definition, etiology, and features of the class 2 division 2 malocclusion, and the last thing we're going to do is to discuss management of class 2 division 2 malocclusion. So the definition of class 2 division 2 is basically when the lower incisal edge occludes posterior to the cingulum plateau of the upper incisors. So as you can see here, that's a class 2 definition, while the upper incisors are retroclined and the overjet is usually reduced. So it's in the opposite to the class 2 division 1, where the upper incisors are either average or proclined and the overjet is increased. Class 2 division 2, the upper incisors are retroclined and the overjet is usually reduced. And the one who came up with this definition is again the British Standard Institute. So what are the etiology / features of the class 2 division 2 malocclusion? We're going to start as usual when we discuss etiology, talk about skeletal, soft tissue, and dental factor, starting with the skeletal. And again, when we do the skeletal factors, we always consider them in anterior-posterior, vertical, and transverse dimensions. Starting with the anterior-posterior one, usually when you see a patient with a class 2 division 2, you expect that the skeletal relationship is something similar to this one, which basically class 2 skeletal, that's one as a mild, very mild class 2 skeletal compensated by a progenia, which we're going to mention later. So usually class 2 division 2, it happens in a patient who has a mild class 2 skeletal with progenia. However, it also can happen in a class 2 severe skeletal discrepancy, as we can see here, in which the mandible is severely retrognatic and the nasolabial angle is increased. And as you can see, if we measure the overjet from the lateral incisor, it will be a huge amount of overjet. So class 2 division 2 can also occur in a class 2, severe class 2 cases in which the mandible is protruded. And also, it can happen in a class 1 malocclusion. As you can see here, the chin is in the normal position. So basically, the patient has a class 1 skeletal and he has a class, or she has in this photograph, a class 2 division 2 malocclusion. However, the most common skeletal feature of the class 2 division 2 malocclusion is a mild class 2 case where the chin is progenic. However, it can happen with severe class 2 skeletal, as we saw, and also it can happen in a class 1. However, it's very rare to happen in a class 3 malocclusion, but it could happen, but that's extremely rare. So what about the vertical relationship? Well, it's come to vertical relationship, it's kind of very specific for a class 2 division 2. Most of the patients with the class 2 division 2, they will have anterior growth rotation, as you can see. So here it's the class 2, severe class 2, class 1, all of them, they have an anterior growth rotation of the mandible. Now, this anterior growth rotation will result, now if we think about it, the anterior growth rotation will result in the rotation of the mandible upward and forward. So forward, it will become less severe class 2, and upward, it will result in reduction in the lower facial height and deep overbite. So we expect when we have a patient who has an anterior growth rotation to have a reduced lower facial height and to have a deep overbite. However, this is not the case always. Now we're going to get deep overbite, that's true, but sometimes you have an anterior growth rotation, but that did not result in a deep overbite. It does not result in a reduced lower facial height. So if you see a photo here for Carolus Maha, for example, if you can see, she has an anterior growth rotation. But what happened is that the rotation took place around the central incisor so that the ramus height become increased. So the posterior facial height is increased, but the anterior facial height is still normal. So you can't always say that anterior growth rotation will result in reduction in the lower anterior facial height. What would we say that in most of the cases it will, like if you see here, the lower facial height is normal, although she has an anterior growth rotation. So what we can say is that anterior growth rotation is a kind of dominant feature of a class 2 division 2 malocclusion, which in most of the cases will result in reduction of the lower facial height and deep overbite. However, this is not in all the cases. This is in most of the cases, but not all of them, as we can see here. However, it's a kind of typical and feature for anterior growth rotation and class 2 division 2 that all of them, as you can see, they have prominent chin. All those patients have class 2 division 2 malocclusion. All of them, they have anterior growth rotation. All of them has progenia. So that's kind of typical feature for patient who has anterior growth rotation and the patient who has a class 2 division 2 malocclusion. And also because the mandible is rotated upward and forward, the angle between the ramus and the body of the mandible, which we call it the gonial angle, which is this angle, it will become reduced. Because if the mandible is going downward and backward, this angle will become increased. But if this angle, if the body of the mandible is going upward and forward, this angle will become reduced. We call it the gonial angle. So that was about the vertical relationship. What about the transverse skeletal relationship? Usually class 2 division 2 patients, they have a symmetrical or like no clinically significant asymmetry when they check their faces. It's not like again class 3, which will be covered in the lecture inshallah. Now we've finished with the skeletal discrepancy. To summarize it, in the anteroposterior dimension, we said that mostly patients mild class 2 skeletal. However, it could happen in a severe class 2 skeletal, it could happen in a class 1 skeletal, and very uncommon to happen in a class 3. In a vertical dimension, we said all the patients with a class 2 division 2, they usually have anterior growth rotation that in most of the cases will result in reduced lower facial height and deep overbite. However, not all of them, because sometimes this growth rotation will happen and result in increase in the posterior facial height, so the lower anterior facial height will stay normal. So we will have anterior growth rotation but not associated with reduced lower facial height. And also those patients will have a prominent chin, we call it progynia. These patients will have a reduced gonial angle because of the anterior growth rotation. While transverse relationship, they always have a pretty much symmetrical face. Now what about soft tissue? Does soft tissue play a major role in a class 2 division 2? Actually, yes. Actually, lips are the main etiology for the class 2 division 2. Because what is gonna cause the retroclination of the incisors? Why these incisors are retroclined? As you can see here in the photograph, there's two things that resulted in the retroclination. The first one is what we call it strap-like lip. So basically the lip is very strong, that it is able to retract and push the teeth backward. And also what we call it a high lower lip line. Usually the lower lip line actually should cover the incisal third of the upper central incisors. But in a class 2 division 2, you can see that it's covering more than half of the clinical crown. We call it high lower lip line. And this high lower lip line will result in retroclination of the upper and lower incisors because the lip is strong, we call it strap-like lip, and also it has a high position to retract the incisors. If you see for this case, for example, you see all the teeth are retroclined, but this upper right lateral incisors. And why is that? If you look at the patient, you can see that she has a strap-like lip. The lip line is high, but because the lateral incisor is shorter than the central, they can escape the control of the lip. And the lip only control the central, and the lateral in this case, and result in the retroclination. So the lip in a class 2 division 2 is the main etiological factor. How much it covers from the teeth, how much of them are they going to be retroclined. So this is another case in which it shows you that the lip is only controlling the upper incisors. And this retroclination will result not only in retroclination, but also extrusion of the incisors. So if you can look at the gingival margin of the canine, lateral, and the central, you can see that the central incisor gingival margin is more incisally compared to this one, which means that the incisors are not only retroclined, but also they are extruded and retroclined, which will deepen the bite even more. Because we know that retroclination of the upper and lower incisors will deepen the bite. So in this case, retroclination will deepen the bite, and also extrusion will deepen the bite. So here we can see a typical feature of a class 2 division 2, in which, because the lateral incisors are slightly shorter than the central, they escape the control of the lower lip, which is very strong, and retract the upper incisors, and the lower upper lateral stay where they are, and sometimes become flared and proclined, as you can see here, with rotations as well. It's quite often that we can see that the lateral incisors are rotated on a patient with a class 2 division 2 malocclusion. And also, what's the typical feature for a class 2 division 2 patients? That we mentioned that they have prominent chin because of the anterior growth rotation. They also has a prominent nose. So they have prominent chin, prominent nose, which means If you are going to plan any treatment for this patient, we said that this is in most of the patients, they have prominent chin and prominent nose. Not all of them. Most of the patients, they have prominent chin and prominent nose. So if you have to plan a treatment for these patients, all what you want to do is to push these lips forward and not to retract them backward. So our preferred treatment plan, always with a class 2 division 2, is to push the incisors forward and give support for these lips, and not to do extraction and retraction of these incisors, causing a dishing in of the profile. And also don't forget, and we're going to discuss this later on the management, that extraction and retraction will even deepen the bite that is already deep in a class 2 division 2 malocclusion patients. That's why you don't want to extract in the class 2 division 2, because you don't want the patient's profile to look like this concave profile. The patient has a prominent nose, prominent chin, and then if you do extraction and retraction, it will even make it worse. All what you need to do is to push the teeth forward. That was about the soft tissue as a part of the etiology. Then we talk about the local and dental factors. So if you look at usually the root and the crown, usually the crown and the root have a little bit of a small angle between them. However, when we have a class 2 division 2 malocclusion, this angle will become increased, because simply the incisors the crown will be tipped slightly positioned posteriorly. So if you look here at the crown, it will look like something like this. So we have an angle that is reduced between the root and the crown, which will even make that kind of part of the etiology. Why do we have retroclined upper incisors? And also, if you notice, they have underdeveloped cingulum. The cingulum of the incisors will be slightly underdeveloped compared to the normal situation. And also, if we measure the arch length, and just to remind you what is the arch length, it is the line that goes from the incisors, central incisors, to the line that is joining the two posterior molars. So the molars are not incorporated or not part of the arch length. Now, because of the retraction of the incisor, because of the retroclination of the incisors due to the lip action, the arch length will become reduced. So for example, if we compare these two lines, this is the line of the lateral incisor, from the lateral incisor, which escaped the control of the lip. That's what the upper incisor should be if the lip is not causing retroclination. We can see that it's longer than the blue line. So which means that the retraction of the incisors due to the lip activity will shorten the arch length. And also, when you do retroclination of the upper and lower incisors, you are moving the incisors from a bigger space into a smaller space. By doing that, the teeth will be crowded. So you're pushing the teeth posteriorly, that will result in the teeth to be crowded. So it's quite often, especially in the lower arch, to see a crowded lower arch. And in the upper arch, because of the activity of the lips on the central incisors and sometimes the lateral incisor escape, we notice that in the upper teeth, the upper incisors are retroclined. The laterals, usually they are flared and rotated, while the lower arch, because of pushing them backward, they will be crowded, as we can see in this photograph. Now, generally speaking, patients with a class 2 division 2 malocclusion, they have wide maxilla. So when you have a wide maxilla, we are expecting to have a scissor bite, as we can see in this photograph, in which the maxilla is wider than the mandible, and this is something we expect to see in a class 2 division 2 malocclusion. And also, those patients will have a deep overbite, because we know that retroclination of the upper and retroclination of the lower will deepen the bite. And this is very important, and that will affect our management as well. So patients with a class 2 division 2 usually have a deep overbite because of the retroclination of the upper and lower. As we can see again, we always have to know that retroclination, as if you are closing a gate of the bridge, that will result in increase in the overbite, while retroclination will result in increase in the overbite, while proclination will result in reduction of the overbite. So now, class 2 division 2 patients, they usually have a deep overbite because of the anterior growth rotation and because of the retroclination of the upper and lower incisors. Now, because we have retroclined upper and lower incisors, and because we have a deep overbite and anterior growth rotation, it's quite often expected to see traumatic overbite. because its overbite is severe. Just to see how much of the upper incisors is covered by the lower incisors are covered by the upper incisors, which means that we have sometimes traumatic overbite. Not only from the lower teeth to the palate, but also it can be from the upper incisors to the labial surface of the lower incisors. Again, why is that? Because we have anterior growth rotation, we have retroclination of the upper and lower incisors, so we have deep overbite. And deep overbite is part of the kind of management of a class 2 division 2 malocclusion, because it's a kind of predominant feature in this kind of malocclusion. Usually the buccal segment relationship of a class 2 division 2 is a half unit to class 2 buccal segment relationship, which means we need to correct this one into a class 1. So that was all for the features and etiology for the class 2 division 2 malocclusion. Now we will talk about the management of a class 2 division 2 malocclusion. It's always like this. We have 4 treatment options. Number 1 is accept, number 2 is the growth modification, number 3 is camouflage, and the last one is orthognathic surgery. And again, to which one are we gonna go for? It depends on the patient's age, patient's concern, patient's profile, and definitely the severity of the malocclusion. So patient's age, for example, if the patient is young, we can try functional appliance. If the patient is adult and the malocclusion is mild, we can go for camouflage. If severe, we can go for surgery. Patient's concern, it depends on the patient. If, for example, patient come to the clinic and say, I don't like my chin, or I don't like my face, the only option to be done is to go for orthognathic surgery. But if the patient is not complaining there's no concern about his profile and his profile is well balanced, then we can simply go for a camouflage treatment and no need. For example, if you compare these two patients, for example, this one have a class 2 mild with a prominent chin, while this patient has a class 2 which is severe. Now, this patient, if she came complaining about her profile, saying, I don't like my profile, then you need to wait and do surgery. But this patient has a pretty much good profile and she has no complaint. She simply said, I don't like my teeth. So we just have to treat her in a way that will improve her profile, but surgery is not indicated. However, if you look at this patient here, if he came to the clinic and say, okay, I don't like my chin, he was very clear that his chin is the problem. So here we have to go for orthognathic surgery. So first option of the treatment is always accept. When would we accept class 2 division 2? As you can see here, the patient has a class 2 division 2. Patient has only mild crowding and deep overbite. So the question is, can we leave deep overbite untreated? The answer, it depends if it's traumatic or not. If there is trauma resulted from the deep overbite, ulceration of the upper gum recession in the lower, then the answer is no. We can't leave this one. We have to treat this deep overbite. If this deep overbite is associated with attrition or a risk of attrition, we have to treat this deep overbite. However, as in this case, there's no trauma resulted from the upper incisors to the palate. There is no trauma to the incisors to each other causing attrition. The crowding is very minimal. The patient is not concerned about it. Then the answer is accept. There is no need for treatment. Then we go for the second option of the treatment, which is growth modification. So if you look at this patient here and you assess her anterior-posteriorly, you can see that she has a class 2 skeletal relationship with the etiology of the retrographic mantle. Now, she is class 2 patient. She is 12 years old, which means that she is in the growth spurt, so we can use functional appliance. And simply what we can do with the functional appliance, as we do usually, twin block to posture the mandible forward. So let's see her teeth in the intraorally. We can see that she is in the full permanent dentition. She has a class 2 buccal segment relationship. But if you notice that she has a class 2 division 2 incisors, and by definition of a class 2 division 2 incisors, the overjet should be reduced. So now the overjet is reduced. If we decided to go for functional appliance treatment, we have to posture the mandible forward. But then we don't have an overjet, so how are we going to posture the mandible forward? How are we going to, like in a class 2 division 1 malocclusion, we push the mandible forward because we have a huge amount of overjet, but now overjet is reduced. So what we have to do is first convert the patient from a class 2 division 2 into a class 2 division 1 incisor relationship. By that, we procline the upper incisors and we create overjet. That will be stage number 1 of the treatment. Then we go for stage number 2, in which we position the mandible forward using, for example, twin block or medium opening activator that will posture the mandible forward. That will be stage number 2. And then, because we have multiple rotations and we know that removable or functional appliance, they can't deal with rotations and multiple tooth movement, we have to go for a third stage of fixed orthodontic appliance. So, when I need to treat patient with a class 2 division 2 malocclusion with functional appliance, there is an extra step in which I have to procline the upper incisors to create an overjet and convert the patient from class 2 division 2 into a class 2 division 1. And definitely, because we said that one of the features of class 2 division 2, that the lateral incisor will be rotated and proclined, lower incisors will be crowded, so definitely then you're going to need a fixed appliance treatment to correct these kind of tooth movement. Now, there's a modification that we can do to the twin block in which instead of making 3 appliances, removable, then functional, then fixed, we can add the component that will procline the upper incisors into the twin block appliance. So we call it modified twin block. Like you see here in this patient, what we did is we have the same twin block upper, but we added with the twin block, we added a double cantilever to procline the upper incisors. And when we register the bite, this is the twin block, how the patient is posturing the mandible forward. And when we did the bite registration, usually when we do bite registration for a class 2 division 1 cases, we take the bite with an edge-to-edge position. But in this case, and in all class 2 division 2 cases in which we use functional appliance to procline the incisors as well, we register the bite in a negative overjet to accommodate or to anticipate or to compensate for the proclination of the upper incisor that we are doing during the treatment. So if you can see here that the patient is not biting edge to edge, on the opposite is having a minus 3 millimeter or minus even 4 millimeter of a reversed overjet. That will be corrected by the proclination of the upper incisors to convert the patient from class 2 division 2 into class 2 division 1. By doing this, we save appliance, so we don't have to use now removable appliance, that will cut the cost. And also we save time, because if you're going to use a removable appliance to procline first, that will take a certain stages of treatment, and then a second stage in which you're going to do twin blocks, so that kind of two steps that can be squeezed into one step, that will result in a kind of quicker result. And also don't forget that if you convert the patient into class 2 division, from class 2 division 2 into class 2 division 1, he will look more severe. And he will end up with a huge overjet that most likely the parents and the kids will not like. So we strongly now recommend that you can use the modified twin block. So it's better in all ways. You save time, you save money, and you achieve a better patient satisfaction. So again, for this patient coming back, we did a twin block for her in which we proclined the upper incisor as well as advancing the mandible using the functional appliance. And to be able to do so, we have to make sure that we register the bite with negative overjet. Then we go for a second stage or for orthodontic treatment, because we fixed appliance, because we need to correct the rotations, we need to correct the crowding. It's always that we need to do a second stage of fixed orthodontic appliance, and here with the patient finished with treatment. So that was how we do the functional appliance treatment. And this is how the patient looked like after the treatment. You can see that they have a slight improvement on the chin that happened due to the growth. Now, what about the camouflage treatment? This is the third option of our treatment, is basically we're trying to mask the skeletal discrepancy. So start with this patient first. As you can see here, she's still growing. She's still 12 years old or 13, but if you can see that the skeletal discrepancy is very minimal. Very minimal skeletal discrepancy, and also the chin is prominent, so we don't need or we don't have to posture the mandible forward. That's from extraoral point of view. If we go intraorally, we can see that she has class 2 buccal segment relationship. She has a retroclined upper and lower incisors, and most important, she has a deep overbite. And you can see the deep overbite is always a typical feature of a class 2 division 2 malocclusion, in which we have to deal with this deep overbite. So when we do the treatment with the class 2 division 2, we have two options always for the treatment. We have extraction option, and we have to do the non-extraction option of treatment, and we're going to explain now which one we're going to go for. So if you compare these two patients, as we mentioned, both of them are adult patients, both of them are a grower, but this one has a prominent chin that we don't need to advance it using functional appliance. That's why we're going to go for camouflage, while this patient has a retrognathic mandible. Now, talking about the deep overbite, how are we going to manage this deep overbite? Simply, if you procline the upper and you procline the lower incisors, the overbite will be reduced. So method number 1 in correction of the deep overbite that is accompanying class 2 division 2 is to do simply proclination of the upper and lower. We mentioned before that retroclination will deepen the bite and the opposite proclination will reduce the bite. So number 1 in which we can deal with this deep overbite is proclination. Number 2, we can simply use what we call it flat anterior bite plane, in which the teeth, we have a separation between the posterior teeth that will result in extrusion of these posterior teeth and reduction of the overbite. However, remember that we can use this technique only in a growing kids, not a non-grower. Why? Because when we place a flat anterior bite plane, the posterior teeth will extrude. And as a result, the posterior facial height will increase. When you increase the posterior facial height, you are kind of stretching the masseter muscle and the pterygoid muscle in the posterior side of the face. If the patient is a grower, they will be okay with this and remodeling will happen and the results will be stable. But if the patient is adult and he's non-grower, what's going to happen? The patient will not like the stretching of the masseter and the pterygoid muscle. So what's going to happen that this muscle will kind of compress and stretch back and kind of squeeze the jaw posteriorly, causing intrusion to the molars, causing relapse for the anterior deep bite. So flat anterior bite plane is an option in a grower kid. The third option, which we usually use in patients who are not grower, is to use something we call it utility arch wire, and this one is used with fixed appliance. It has utility arch wire, you can call it bypass arch wire, in which the wire will go from the molar, then go up, bypassing the premolars, that's what you call, and the canine, it's called bypass arch wire, and then engaging the incisors. And what you need to do is to bend it upward. As you can see in this video here, that was going to happen. You're using the molar for anchorage and then you lift up the incisors. We use this technique especially when we want to improve the amount of the incisal show and smiling. Instead of having gummy smile, you intrude the incisors instead of extrusion of the molars. And also in a patient who's non-grower, you can't extrude the posterior teeth, so simply you intrude the anterior incisors. Having said all of this, please keep in mind that this process is not extremely difficult, but this one is challenging. It's not an easy step to be done. It's much easier to procline, it's much easier to extrude the posterior teeth, but intrusion of the anterior using this utility arch wire is not a straightforward and easy one. And also remember that this one will be done only by the orthodontist. So this is a real photograph of the bypass arch wire. You can see that this wire going this way, down and up again. So we have another segment of the wire to hold this posterior segment together. And this wire will have a bend here in the wire that will cause intrusion to the incisors. So it will move the incisors downward. Again, remember this movement is not quite straightforward and easy treatment, and that's done by fixed appliance. So what we did with this patient to reduce the overbite. Now, number 1, she having incisors that are retroclined. So what we want to do is to push these incisors forward. And if you look here, so we had the upper incisors are retroclined, lower incisors are retroclined as well, and she has a crowding. So do we have to do for extraction or proclination? We mentioned that retroclination will deepen the bite. So simply, if you have this amount of crowding and you decided to extract the teeth, what's going to happen to these teeth? That it will be slightly retroclined. And this retroclination will make the bite worse. So if you have a mild decrowding, in this case, we prefer to go for the non-extraction option, proclination of the teeth. That will result in a better profile in this case because of the prominent chin and the prominent nose. So a decision of the extraction and extraction is multifactorial, but in this case, one profile, we would like to procline the incisors because she has a prominent chin and prominent nose. She also has a deep overbite that will be even getting worse when we do the extraction. So usually in a class 2 division 2 cases, we go for the non-extraction option of treatment. And it's quite often, it's really difficult to do the space closure as well. If we do the extraction, the spaces will not close in a class 2 division 2. So for many reasons, again, profile-wise, overbite and space closure difficulty, it is better to treat the patient in a non-extraction fashion in class 2 division 2 malocclusion. Now also we still have to manage the deep overbite. We mentioned we're going to treat the patient non-extraction, so we're going to procline that will reduce the overbite, and we can do both. We can add as well flat anterior bite plane. Now flat anterior bite plane can be done with a removable appliance, and which that has an Adam clasp and it's splinted in the back of the teeth, or if we want to do the treatment at the same time, in which we procline the incisors doing fixed appliance and using a flat anterior bite plane at the same time, we have a bondable flat anterior bite plane. As you can see, this one and this one, we bonded these teeth in the posterior, in the link palatal aspect of the upper incisors, as you can see here, and then this is the lower incisors biting on the bite turbus, so we have a separation of the posterior teeth. Now what's going to happen? The posterior teeth will extrude and the overbite will be reduced. At the same time, we are doing proclination of the upper and lower incisors. So we are correcting the overbite in this case by two mechanisms, proclination and extrusion of the posterior teeth. It is stable because the patient is a grower. It's better for the aesthetic because the patient has a prominent nose, prominent chin. We don't have to go for extraction. And this is the patient during the treatment. And this is how she looks like before and after. Look now how the overbite is corrected. Now it's before, the patient's hardly showing any of the incisors, while here the patient have a normal overbite. And this is how the profile look like. Usually the profile, at least, is not getting worse. You can see that support has been given to the upper and lower lip. So remember again that extraction, we usually our first treatment option with the class 2 division 2 is non-extraction. However, having said that, it's not always like this, because sometimes we have to do extraction treatment. Like here, if you can see that the amount of the overjet is 9 mm from this lateral incisors. Molar relationship is a full unit class 2. Canine relationship is a full unit class 2 as well. Patient's profile, the chin is in the correct position, but the cause of the problem is a prognathic maxilla. The etiology is maxilla. The etiology is not mandible. So if you protrude the mandible, as we did in a functional appliance case, for example, or orthognathic surgery, the patient will be looking like a bimaxillary protrusion. So in these cases, although we know that we don't like extraction in class 2 division 2, but in this specific particular case, extraction is beneficial for the patient. And that's exactly what we did. We extracted 2 units in the upper arch only, and the profile of the patient, as you can see, we retracted the incisors. Improvement of the profile, yes, but she lost a lot of weight as well. That affected her profile as well. However, profile look much better at the end. So again, most of the cases, let's say most of the cases of a class 2 division 2, we tend to treat them in a non-extraction fashion to maintain the patient's profile and the overbite of the treatment, because it will be deepened by the extraction. However, in certain cases in which the maxilla is the etiology of the problem, we go for the extraction in the upper. This is the patient before and after the treatment intraorally. As you can see, she lost 2 premolars. For that reason, she has a full unit class 2 molars on both sides. Canines are class 1, overjet is reduced. Now the last option is orthognathic surgery. So if you can see this patient, as we mentioned before, he has a retruded chin, and the main complaint for the patient is the retruded chin. If you look intraorally, he has a huge overjet. It's almost like 10 millimeter of overjet. So we did something we call it decompensation, in which we provide him with a huge overjet, and then the surgeon did the surgery in which he advanced the mandible forward. So first you need to give the space by proclining the incisors, and then the surgeon will advance the jaw forward. That will be covered in a special lecture again later this semester. And this is the patient after 1 year of the surgery. Last topic to be discussed today is retention. So basically, when you treat a patient with a class 2 division 2, the stability thing, we have 2 kind of challenging situation, tricky situation. Number 1 is to maintain the deep overbite correction. We have a deep overbite, we need to maintain it as we reduce it to a normal overbite, so we have to maintain the normal overbite. And also, it's quite often to see a rotated lateral incisors, and as we're going to cover in a lecture later this semester, we know that rotation is one of the most difficult to retain because they tend to relapse immediately after the treatment. So, what are we going to do to get a stable results when it's come to the deep overbite? Now, as we mentioned, when we treat the patient deep overbite, what we need to do is to intrude or procline the lower incisors, and then if you don't get an interincisal angle that is proper, like if you correct the deep overbite like this, but it still has an increased interincisal angle, the lower incisor will tend to extrude again, and there is no stop that will prevent them, so they will slide and we will have relapse. To prevent this, we should have what we call it a good interincisal angle of 133 plus minus 10. So basically, when you have this kind of interincisal angle, it will act as a stopper. It will prevent the eruption, the over eruption of the incisors. It will have control of the upper incisor on the lower incisors. And as well, it's called a lower incisor. Another way to measure it, the lower incisal edge should be anterior to the centroid, or like the middle of the root of the upper central incisors by almost 2 millimeters. So when you have this anterior to the centroid by 1 to 2 millimeters, that means any extrusion of the incisor will be stopped by the upper incisors. So these two factors that we need to look at to achieve a stable overbite: interincisal angle of 133 plus minus 10, and the lower incisal edge to the centroid with the upper, they should be anterior to that point by maximum 1 to 2 millimeters to get a stable overbite correction. Then that's how we deal with the overbite. What about the rotations? What shall we do to maintain the rotation? Simply, we have to use a fixed and bonded retainer. Fixed bonded retainer that will prevent the relapse of the rotation. Now, the last thing to mention about retention as well, we said that we prefer in a class 2 division 2 cases to treat the patient in a non-extraction fashion in most of the cases in which we procline the upper and lower incisors forward. And don't forget that we have the equilibrium theory of Profit, in which it said that the teeth are in a state of equilibrium between the forces from the tongue in the back and the forces from the lips from the front. So if we procline the upper and lower incisors, then we are invading the lip space and causing a relapse. However, the theory, if we go back to this photograph, the theory is not like this. If you look here at the the upper and lower incisors, they are both retroclined, and the upper incisor is completely covering the lower incisors. So there is no genuine contact between the lower incisors and the lower lip, which means that there is no control from the lips to the lower incisors. And that's not considered normal equilibrium theory. So in a class 2 division 2 cases, as an exception, in theory, proclination of the upper and lower incisors will not result in a relapse, and also we can procline them by more than 2 millimeters, not like the other malocclusion, simply because there is no, before treatment, no contact between the lower lip and the incisors. The lower incisors, it's only a contact between the lips and the upper incisors. And that's what all we talked about, and that's it. Thank you very much for listening.